So good evening, friends. We bring to you the webinar with Foxy Medical Disorders in Pregnancy Committee with Rewari, Gurgaon, Yamunanagar and Hisar societies. And this is a webinar in attempt of bridging Bharat, going to the societies and visiting those societies, knowing what are the common problems there, and accordingly designing a unique webinar targeting special topics, that is newer concepts in management of diabetes in pregnancy and alloimmunization will be covered in today's webinar. I take pleasure as a chairperson of Foxy Medical Disorders in Pregnancy Committee to be among you and coordinate and moderate this webinar. This webinar of Foxy Medical Disorders in Pregnancy Committee we have been conducting and plan to conduct at every corner of India so that we know the common causes of medical disorders, what problems our obstetricians are having in day-to-day practice, and can help them, guide them in academic way when this lockdown is happening, and brush up our knowledge in the various medical disorders which complicate the pregnancy. So to begin with, we have with us none other than, next slide, Dr. Hema Divakar Madam, who is the authority in the topic of diabetes. You know the name diabetes in pregnancy and what comes into your mind is Dr. Hema Divakar. So she herself has agreed to be with us, share the platform and address us and answer all our common queries. Madam was the President Foxy 2013, Consultant of Divakar Specialty Hospital, Bangalore, Foxy Ambassador to FIGO, Vice Chair FIGO GDM Working Group. So we have the opinion and the word from the FIGO. So we will know what are all recent guidelines in diabetes in pregnancy today. CEO Chairperson of ARTRIS, Asian Research Training Institute for Skill Transfer, Technical Expert Institute of Public Health, Government of India, received the FIGO International Women Achiever Award 2015, ex-Senior Vice President Foxy, ex-ICOG Honorary Secretary, actively working with the GOI on research projects in rural India, and National Teaching Expert for Skill Birth Attendant Training. This is just the concise few lines which I have spoken about Hema Divakar Madam, but her CV runs down into many pages, and we are really honored to have you. Thank you, Madam, for being here. Welcome, Madam.
Namaskar. Thank you very much, Komal. And as you have just said that we are on a virtual tour, would you want to introduce the other panelists or should I go?
We'll just introduce them, everybody, so they are all there, and welcome them, and then we can start, Madam.
Yeah, thank you very much. Yeah.
So we have with us here Dr. Seema Mittal, who is the President of Rewari Obstetrics and Gynecological Society, and she is the one coordinator or initiation for which we have coordinated with the other societies. She has taken the lead and done this webinar for the Haryana Society. Thank you very much, Seema Mittal. And she's an infertility specialist practicing at Sevagram, FICMCH, Lalita Memorial Hospital, and the first IVF center in Haryana. She is the current president of Rewari Society, Secretary Doctors for Society, past treasurer Indian Medical Association Rewari, executive member IFS Haryana, and received award from President for a book, Sukhat Matritva. Welcome, Madam. Next slide. We have with us Dr. Sarita Gulati. She is the President of Yamunanagar Obstetrics and Gynecological Society, MBBS DGO from PGIMS Rohtak, worked as SMO and in charge Gynec and Ops at Civil Hospital Yamunanagar, presently working at Gulati Hospital Yamunanagar, field of interest in fertility and obstetrics, Vice President Foxy year 2017-19, presently President Foxy Yamunanagar. So we have Madam representing Yamunanagar. Welcome, Sarita Gulati Madam. Next slide. Dr. Subohi Rizvi. She is heading the Complete Women Care Mother Clinic and Ultrasound Center, certified as an ultrasonologist with special interest in maternal and fetal medicine, certificate of competence in color Doppler ultrasound, and certificate of competence in pre-eclampsia screening national medicine course. She has a certificate course in abdominal and OBGYN ultrasound, conducting workshops in school, corporates, and community center for the last 14 years. And presently, she is a secretary of Gurgaon Obstetrics and Gynec Society. So we have Dr. Suboi Rizvi representing Gurgaon. Welcome. Next, we have Dr. Preeti Jain, Secretary of Hisar Obstetrics and Gynecological Society. She has done fellow in minimally access surgery, MSI, presently working as an endoscopic surgeon and obstetrician at Govind Nursing Home, Hisar. Her special interests are high-risk obstetrics and gynec endoscopy. Welcome, Dr. Preeti Jain, and on behalf of all the society representation and me with Foxy, we all welcome jointly welcome Dr. Hema Divakar, Madam, and the dais is yours, Madam, and we are very eagerly waiting to hear from you. Thank you, Madam.
Yeah, this is truly building Bharat, Komal. I really congratulate and appreciate Seemaji, Sarita, Shubhohi. Incidentally, all the names start with yes. So can we get a handle on diabetes in pregnancy in our country? We'll say yes, yes, yes 3 times because we have 3 S's with us, and Pyar Se because there is Preeti Ji also joined us, which have brought us together on this lovely platform, because enough is not enough on this issue, and we need not only to know but to translate it into practice. Given the time constraints, given every other challenge that we have with the patient's understanding, it is not a one-day, one-time care. There's a long-term something that she needs to do for herself. It is exceedingly difficult for us to implement this into practice. That is the gap, building Bharat, that we have to bridge. And we have recently launched a project called Sweetheart. It's an easy thing to remember, all of you. Sweetheart, sweet disease today is heart disease tomorrow. So that is the kind of mindset that we have to work. Today we may be dealing with pregnancy with hyperglycemia or high blood sugars, but tomorrow she will go and land up with type 2 diabetes, cardiovascular diseases, which is a serious comorbidity for elderly in the country, which is taking a toll in the COVID pandemic. So this is really our responsibility to do our best for 2 generations, this mother and the baby which is getting programmed in her womb. So with that, let's see how we can embark on doing our very best bit. We have proved to the world that despite all the constraints, we are sorting out innovative methodologies by which we can tackle the COVID crisis. Yes, there have been pangs of panic, but there have also been rays of hope, and we are self-confident now that we will find a way around. So just permit me a minute to share the slides on the whole scenario of diabetes in pregnancy in the Asian region. Because what we do in India today in multiple numbers have proven a role model in the rest of Asia. So if each and every OBGYN, each and everybody in the chain of healthcare providers keeps doing as per the global recommendation adapted to the local context. That's why we say global problems, local solutions, because we have to do some things a little differently. And that is where my voice as a vice chair in the FIGO circles, when I almost stood up on the chair and said, no, this is something which is very tough in our country. No, let's innovate in a different way and adapt the single step test. That's where we were. And you see the red bar. SEA is Southeast Asian region. It ranks very, very high in the numbers because we are just so many in the country and in the whole of Asia. So 3 out of 4 people living with diabetes anywhere in the world are concentrated in the low and middle income countries. So if at all anyone is still thinking that this is a problem for affluent countries, sorry, no, it is all concentrated right here. And South Asians are 11 times more prone for high sugars in pregnancy than the rest. So we need really to take care with a lot more seriousness pre-pregnancy, in pregnancy, and long after the pregnancy and delivery is over, we have to constantly pay attention. So whether it is RH-ISO immunization that is being discussed or any other topic, medical disorders, the underlying thread, Komal, is hyperglycemia in pregnancy, which should always be high on our minds to do what can be controlled. And 1 in 5, 1 in 6 babies were born out of mothers with high sugars. Now this ratio is becoming every 4th baby in the country is being born to a mother with hyperglycemia. The sad thing is that more than half are not diagnosed at all because there is no concept of preventive care. Majority of the people with pre-diabetic conditions remain undiagnosed and unaware, particularly the young and the women, because they never get to go for the testing. This is all about gender inequity, which is still rampantly existent in many parts in the societies that we are addressing today. For example, I'm sure they have additional constraint of the women being given the second priority. So they never ever go for any kind of testing. And sadly, if they do show up and we don't test them, then the responsibility and the onus is with us. So we are aware, but we have to move from awareness to action because we want to move from illness to wellness. It's been our dream to collaborate with just about anyone and everyone to see that we prevent illness and promote wellness. So the advocacy, the capacity building, research, more data, and more action. You will see all the leaders here, including our prospective next president of Foxy, Dr. Rishikesh Pai, who we have taken to the streets with a mission of defeating diabetes and not allowing India to become the diabetic capital. So what is the first step that we need to take? It's called the Pehla Kadam. Test everybody, every pregnant woman at least twice in pregnancy. And the reason that we have to take more responsibility is because in a healthy pregnancy, if there is a harboring of a wrong environment with a low birth weight or a high birth weight, either of the extremes, then this child will go and land up in its adulthood with the increased risk for obesity, for cardiovascular disorders, and for diabetes. And that again goes on to the next generation. So it's a big vicious cycle moving on and on with generations. So though we call it an NCD, non-communicable disease. So I have diabetes, I cannot give it to my neighbor or anybody else in the family, but it is communicable from the mother to the baby in the programming for early onset adulthood diabetes. So in that sense, we say it is intergenerational transfer. That component is communicable because from the pregnancy, it will go and program the child to unfold with a sedentary lifestyle, with the wrong food habits. Already the seeds are sown when the child was in the womb, and it will bloom by 20, 22, 25 years of age into PCO-related obesity with impaired glucose tolerance and early onset type 2 diabetes, and so on and so forth. So all our campaigns, our training program, our awareness program have to focus that we have to convince the governments and the policy makers it is so very important to invest on the pregnant women, because that is our target, where at least the whole generation next we can get them to the lowest levels of non-communicable diseases as possible. So if you just focus your attention for a moment on this slide, you have invested the best in the mother and the infant right at the start. You've tested every woman. You've tried your best to have her sugars under complete control. And this baby is programmed in such a healthy manner that early intervention, you see during the life course, the risk of NCD, which is the vertical y-axis bar, is so little, maybe 10%. You don't do anything, you have the next opportunity in the adolescence and the childhood, because epigenetic problems of lifestyle changes, at least you can advise there. And if that is done, again, you have a little bit more NCD, but still not too much. If you don't do anything anytime, no intervention, look at how high the NCD rate will become. So there's a tsunami of NCD that is already on in this generation. Let us not let it happen for the generation next. We as obstetricians, yesterday we were talking about maternal mortality. we did obstetric emergency care, we did Helping Mothers Survive program, now we're doing Manyata and quality care for safe delivery. Why are we saving these mothers? Just in order to become early onset diabetes, because pregnancy diabetes within 2 to 5 years, if you have not handled it properly, to go and land up in a type 2 diabetes. Then today we are busy tackling the NCDs and the cardiovascular disorders, and many women who are non-smokers and who are not so elderly are going and landing up with the diabetologists and physicians for very many complications. And tomorrow, if we see the sea of the youth, then they are at very, very, very high risk for hypertension, diabetes, and obesity. So let's wake up, and unless we take urgent action and be serious about controlling the sugars after testing every single pregnant woman, and 6 weeks postpartum care is a short-term postpartum. What we need is a long-term postpartum. Please don't let go of these women whom you have tested, whom you have handled exceedingly well in pregnancy. We congratulate you for that. But this woman has to come back every single year to test her sugars, to see to it that she does not turn into a full-blown diabetic. You have to keep on re-emphasizing the discipline into her. So pregnancy is truly a window of opportunity, and we have to marry the mother and child care services to the NCD services such as diabetes, hypertension. That kind of a networking combination, if it happens, then I think seamlessly everybody through their life cycle will be taken care of. So the update in management, actually I would like to emphasize that there is no great update except this one thing which we have added. Oral hypoglycemics were not in the government recommendations until 2018. The first set of recommendations which we made from the government of India was in 2014, where we brought in the FIGO guidelines approved by the global authorities to be incorporated into the government of India guidelines. And what did it say? There were many pockets who fought against us saying, nahi, universal screening, come on, so much of rush is there and so many pregnant women, we can't. We will select them by their age, we will select them by their weight and BMI, we will select them by the previous obstetric history and then do the testing. We said no, each and every pregnant woman in the country has to be tested. And the first screening has to be done at 12 weeks of pregnancy, because she may never ever have been tested before, and it is the first opportunity for you to pick up the high blood sugar as early as possible. If that is normal, then anyhow you have to test it at the appropriate time, that is about 22 to 24 weeks of gestation. And how do you do the testing? Just with a 75 gram of sugar. Don't worry if she is not fasting or otherwise. Then 2 hours later, after having the 75 gram glucose in water, at 2 hours she gives a single blood sample. If the value is more than 140, you will label her as a case of gestational diabetes, presuming that it's 10% of our women. Really, if we test everybody, we will have about 3.5 to 4 million pregnant women in the country who will have high blood sugars. So those are the positive cases which need to be taken care of. And how do we take care of them? 80% of them will settle with the diet counseling and the exercise pattern. But where is the time? Where is the knowledge? Where is the appropriateness and the practicality? What we eat in South India doesn't apply to many other parts of the country. Vegetarian, non-vegetarian, likes and dislikes, everything comes into the picture. We are still struggling to give a quick checklist called Think Nutrition First and empower all the OBGYN and healthcare workers to do better on the MNT, medical nutritional therapy and counseling. With that, if it's done properly, 80% will come under control. The other 20% who don't come under control, we have now included metformin and glyburide as the oral hypoglycemics. There was a lot of fight with the endocrinologists who said, we don't have enough data to say that this is safe. We said, no, we are using in PCOS right, left and center, even through the first trimester. Don't ask us about data. We are going to go ahead and use it. We are familiar with that drug. So finally, with a little bit of data, patchy data produced from here and there. So we urge you, moving forward, if Komal starts a registry and everybody is asked to fill in their data, let's do it, because we can figure out the best way to sort the problems within our own country and the rest of Asia. So oral hypoglycemics, and very, very small percentage, maybe 2 to 5% max, will go on to the insulin therapy. So the universal testing by the single step test, which I told you, many centers still do the fasting and the 1 hour, 2 hour, 3 hour pricks. It's possible only in some niche segments where the patients are willing to come back and forth and take the 4 pricks. But this test has stood as a good alternative to very easily doable, very patient friendly, and no interference with the meal, etc. So nobody can make an excuse that they can't do this test. So the obstetric management, now that you have done this much, the principles are pre-pregnancy. If you would have optimized the care, if you had a chance, she was coming to you because she couldn't, she was coming to you for some other problem, please then check the sugars, see to it that HbA1c and sugars are in the normal level so that she starts her pregnancy with normal glycemia. The normal glycemia in pregnancy and track both the short-term and the long-term problem, because GDM is an intersection of 2 major areas of health. One is maternal and child health, other is long-term problems of NCDs. All of us are resetting and restarting. In diabetes care, our 6th sense. What is our 6th sense? The use of ultrasound. Okay, that is really, really crucial in the decision making. And look at our situation now. We have to reset and restart, put the plastic curtains. We are taking 20 minutes to scan the patient, and you are with a complete dress code, and there is a loophole made over there with which you move the probe and try to get the best of the findings. So the increased incidence of congenital anomalies. That is why I said that in the pre-pregnancy state, if you haven't done enough, then there is a chance that she enters a pregnancy with high sugars, which totally disrupts the organ formation, and there is a 4-fold chance of a congenital anomaly, and it increases with the degree of diabetic severity. When we do the scans, there is no fixed protocol. That's why we say this will take time, this is individualized, and 7 to 11 week scan, because obesity and mild dysglycemia will give rise to abortions by itself. So the viability, etc., early part that you have to do. NT scan, yes, you will do, but you'll ask for an early anomaly scan, because head to toe, a lot of anomalies can happen. Fetal echo is an added component because cardiovascular anomalies are the maximum. Then begins how good your sugar controls are, how often you will need to track the growth profile of the baby and the well-being of the baby, maybe at 28 weeks, 32 weeks, 36 weeks. There's no fixed protocols, and sometimes there is a constraint to call the patient back and forth very often. So 11 to 14 week scan, how much information can we extract from this tiny fetus? High proportions of CNS CVS kidney malformations are reported. Uterine artery Doppler is worthwhile documenting because comorbidities of PIH are also fairly common with the GDM patient. In the second trimester, just the 4-chamber view of the cardiac and the outflow is not good enough. You need to do a color Doppler with the uterine artery notching. The RI is more than 58%, and with the notch, then it's a predictor of PIH. There can be other anomalies related to the cardiac, which will be picked up by the echo. So this has to be a part and parcel. You need probably to refer it to an expert sonologist, but it is worthwhile doing so. After 28 weeks, what happens? You have sorted all this. It's an ongoing pregnancy. All the anomalies and these notching, etc., are ruled out. Then what are you left with? 2 main things again. One is constantly strive to get her sugars in order. Secondly, track the growth of this baby. Abdominal circumference is the key, because if the AC is more than 90th percentile, then macrosomia is a given in 78% of the babies. But it's very difficult sometimes to accurately estimate the fetal weight, because underestimation, overestimation, fat patients, and it's quite a challenge. And oftentimes we'll end up scolding our sonologists if we are not doing the scan ourselves that this was a totally wrong estimate. There is another important thing you have to pay attention to. Even though the patient's sugars are normal, she has met the targets of 90 mg% for fasting and 120 and 140 depending on 1 hour or 2 hour post meal whenever you're doing it. She is in the range. but the AC is increasing. It is showing a macrosomic pattern. Then you may need to add insulin. You may need to have a stringent, more stricter control of the glycemic status, because there is a continuum of, suppose the target for fasting is 90. Maybe her original fasting was 70. For her, 90 itself, though it's an average target, it may be more. That is when she will show the macrosomia. So there is a concept of fine-tuning the insulin requirement or aggressive control of sugars based on the ultrasound findings itself. Can you land up with a situation of a growth restriction or a small, for gestational age baby, tiny baby in a diabetic? Isn't that surprising? Yes, this can happen if there is a vascular disease, very hopeless case where the vessels are impacted. Otherwise, diabetes is a metabolic problem. It is not related to the blood flow in the vessels. Therefore, oftentimes, if there is no PIH, you will find the Doppler as normal. But if there is a super added PIH, or if there is a diabetic vasculopathy, then, or sometimes what happens is you're too aggressive in diet counseling. Poor thing, the patient is not at all eating whatever she's normally supposed to eat, and we sometimes end up with a smaller sized baby. So you've got to pay attention to multiple factors when you're handling this. The problem with the large babies are fetal hypoxia, sudden intrauterine death, birth injuries, inclusive of brachial plexus injury, etc. So you are walking on a very, very, very tight rope. And when you have to decide when to intervene, all obstetricians still feel compelled to use ultrasound to guide the obstetric management of pregnancy complicated by diabetes. Every other visit, we put her up for the scan, measure multiple parameters, because we have no simple and accurate means of assessing the status of the fetus. Though in the corona pandemic, they say that we have to call the patients to the minimal times of antenatal checkup. Anybody with comorbidities, either hypertensive disorders or hyperglycemic disorders, will require multiple visits. We've also shown that every class of Indian women do have a mobile. Many a times you may have to not call them physically, but to discuss with them their queries, being available to them on the telecall or a chat option or a video call. But you must integrate the technology for diabetes care. Do not underestimate our women in the rural areas. What to eat, when to exercise, when to manipulate the insulin dosages and the timing, etc. It can all be conveyed to them through the technology. There's vast amount of data from many sources from within India who have done this very, very successfully. So we believe that it is the technology which will be the innovation in the diabetes space, and not a new molecule of hypoglycemic agent, which is oral, or not a new variety of insulin, but it is indeed the reach to the patients with the technology. Lastly, coming to the timing of delivery, a well-controlled diabetes. That means you've done your best. Everything is going well with the mother. Everything is going well with the fetus. Why will you unnecessarily interfere? Which means that this can be, in your mind, treated as any other antenatal patient that you would treat, with the expected management up to term, but not beyond that. The typical theoretical weight, more than 4 kgs. But in your own setting, you know the average size of babies, and if it's crossing 90th percentile, you will offer an elective section, because nobody wants to get stuck in the last minute with the difficulties in vaginal delivery and birth injuries. Early delivery sometimes will become necessary based on whether previously she has had a stillbirth, where there is diabetic nephropathy, vasculopathy, or very poor glycemic control, and you know you'll land up with an IUD or any other obstetric indication, because comorbidities are so many. The issues with accidental hemorrhage and polyhydramnios, etc. So sometimes you may be prompted to deliver them early, but hopefully not earlier than 38 weeks, because the lung maturity is going to be late. More I think, more I'm confused. Yes, we are all in the same boat, however many diabetic patients which we will handle, because every single case, when you individualize the decisions, it depends on multiple problems, and the ACOG practical bulletin says, depending on the fetal weight, you have to guide them for mode of delivery. The NICE guidelines also says, please place the risks and benefits both of vaginal birth, induction and C-section, because patient has a right to know. she should be involved in the decision making. But we as gynecologists, more often than not, are on the safer side of a C-section. That is, if we touch our heart and see how we are handling, many of the patients who could have delivered normally may be electively posted for section because of several reasons. Spontaneous labor, if the patient comes, she is under good control, she is only on the diet therapy, then admission CTG, monitor the labor with partogram, sugars to be done every 4 hourly, target levels to be maintained between 80 and 110, continuous fetal monitoring, and all should go well and she would deliver. Elective C-section, if the patient is already on insulin, she has to be nil by mouth on that morning. Preferably put these cases, the first case in the morning, early cases, omit the morning dose of insulin. Fasting and serum electrolytes, the blood needs to be drawn for. Post-operatively, the sugars every 2 hourly for the first 12 hours and 4 hourly later. The plain insulin according to the sliding scale, and these should deliver in an institute where at least you can reach the diabetologist by a phone call. Neonatal hypoglycemia is a huge challenge. You have to guide your staff to see to it that she guides the mother for the breastfeeding as soon as possible, and many times in the first 48 hours, because if the sugars go less than 20 or 40, the baby will be very lethargic. You may have to start an IV line for the baby as well, and you may unnecessarily land up into complications. The long-term problems of neonatal hypoglycemia may translate into cerebral palsy, epilepsy, cognitive impairment, visual problems, developmental and behavior disorders. Lastly, we can't escape out of talking about COVID and pregnancy. We know that pregnant women are not a special issue for COVID. COVID doesn't distinguish between pregnant, non-pregnant, men, women, caste, creed, economies, geographies, no bar. It'll just go and infect everybody, highly contagious. That is a given. Pregnancy itself alters the body's immune system. By now, everybody is taking some ginger and haldi and things like that to improve their immune system, including of vitamin D, etc., etc. But our worry is for the pregnant women who have had previous heart diseases and who are hypertensive and who have high blood sugars. They are truly at risk. Most of the pregnant women, even COVID positive, will be asymptomatic or mild. But if they have any of these, they can suddenly deteriorate and push themselves into a severe condition where they may need to be, you may need to be on the alert and transfer them to the COVID dedicated hospital. So we close with saying that all of us, when we're writing our COVID diaries, there's a lot of uncertainty, a lot of frustration, a lot of confusion, and we say all of the above, but still Foxy is bringing out the GCPR. Komal and others have put us together to again re-emphasize our resolve that COVID may come and COVID may go. We are the tough people who stay beyond the tough times, and the importance given to GDM as a public health priority cannot be stressed enough that if you had lesser number of diabetics in the country today, then many a severe case of the COVID would have survived. And the long-term health, we go back to the two adages that health is wealth and prevention is better than cure. So every single of these mothers, if they have had hyperglycemia, if you have tested them before pregnancy, if you have looked after them very well in pregnancy, all these little babies are programmed so well that we will definitely have a healthy generation next. So that is the concluding resolve that we need to make with the already burnt out health system that we have. We know we are demanding too much on ourselves if we have to handle such great volumes of diabetics in the country, but looks like there is no other go for this generation. We have to handle it. At least let us make sure that the next generation is far healthier than the existing prevalence of the diabetes situation in the country. So with this, I bring the deliberation to a conclusion, eager to answer your question to the best of my capacity. But I really need each and everyone to be sensitized that this important issue before pregnancy, during pregnancy, soon after pregnancy, and well after pregnancy should never be escaping your mind. And sweetheart is again the concluding phrase for all my colleagues and friends who are with us to dialogue with us virtually on this important issue. And Komal and Medical Disorders team of Foxy, thank you very, very much for this wonderful opportunity yet again. Thank you.
Thank you very much, madam. It was a real great talk, and you have actually gone through every aspect of diabetes so much in depth, and it was so clear. The management, the newer emphasis on the medical management, nutrition therapy, the newer anti-diabetics, and the questions are flowing. We have many questions, most of which you have covered in your lecture. And believe me that now we have almost 500 active users logged in and viewing the webinar, and many more registered. So it is, diabetes in pregnancy is such a topic which is really a challenge for every obstetrician. Though we have every case, we get to learn something new. We always have so many dilemmas, and that is depicted in the questions which have come in my box. And a few questions I'm going to ask you, madam. There is a question from Dr. Anita. She wants to know how to manage a diabetic patient already on medication and now has become pregnant. So is there anything which we have to keep in mind by managing such patients?
See, the best opportunity is if this patient has come to you seeking your advice that now I want to embark on the pregnancy, what is your advice? So definitely the folic acid, HbA1c and the sugar profile, consultation with her diabetologist, so that we need to keep her in the optimal range before she gets to the pregnancy. And almost all the drugs which she's taking will have to be just reviewed once, because many of them are safe in pregnancy, but if her sugars are not under control just with the diet and exercise, and she is on any other oral hypoglycemics other than metformin or glyburide, we may have to shift her to insulin if the oral hypoglycemics do not work. But it's very, very important to keep that window very tight, that her sugars need to be under control before she embarks into a pregnancy. Early part of the pregnancy, there are a lot of issues with the already known diabetics, the type 1 diabetics, because they take the dose of insulin, they may not be able to eat well, or because of hyperemesis, they will vomit so many times. So every day, that is why the telecalls and the digital chat is so very crucial, because she has to be reassured on almost a day-to-day basis, because today is not the same as tomorrow. So early part, that is a issue apart from all the other routine care that you will give. Mid part, again, the hormones, placental hormones will interfere with the sugar monitoring, and already known diabetic will need a diabetologist and physician's care. All her eye checkup, then renal check, and everything else for the major organs need to be surveyed in addition to what we do as OBGYNs. Well, then when we decide, for example, for a C-section, then the wound healing, etc. becomes a real issue. So she has to be in a good antibiotic cover. So basically, it is not easy to have a tight control on the sugars, because you must not swing in the opposite direction, keeping the sugars too tight under control and making the baby sick and tinier than what it's meant to be. In addition to this, if she has PIH, etc. as a comorbidity, it's a huge challenge. These patients should be called at a separate schedule, because time is very, very important. And Shanti said to make notes on what you want to do with her. That is a practical advice. Please don't mix up and mess up with the same vertical of other patients whom you're seeing. If one thing also you skip on one day, it's very difficult to reverse that situation. So you have to be really cautious and guarded.
Yes, thank you, madam. You have emphasized so much on monitoring. And as you have touched about glyburide, so there is a question from Dr. Prasanna. The question is that, is glyburide superior to metformin in pregnancy? So should we consider changing, or metformin is good enough?
No, actually metformin is something which we as OBGYNs are very comfortable using. So our ultimate aim is the target sugar levels. So it's not only the metformin, but you must emphasize to the patient that her small frequent meals with the proper carbohydrate counting, etc., and walking after every meal and that minimal exercises. With metformin, if everything is under control, then maybe as an OBGYN, I may not like to jump to something which I'm not very comfortable. So our main focus remains not on what we're giving her, but whether with whatever we are giving her, is the target achieved. If it is, then we'll choose metformin, though it is, metformin has really not stood the test of time. It is an also ran kind of a oral hypoglycemic that it is becoming in the present era, because the mixed study has shown most people on metformin, as the pregnancy goes on, ultimately they will need insulin. So why start metformin? All the Diabetic Association, American and Indian, they say no, straight away start insulin because metformin is useless. They have come to that conclusion. But we are saying, even if 50% of our patients get control with metformin, then out of 3 million, if the numbers of so many millions can avoid insulin, it is so much better for us to deal with. Because once they get onto insulin, then your drama begins in a very different way. So that's how we
Yes, we always try to delay the start of insulin for a patient because it requires a lot of monitoring. And there is also a question about other oral hypoglycemic drugs, like Dr. Gagandeep Kaur is asking whether voglibose is safe in pregnancy.
No, if you want to, because if you want to go by the government guidelines, बहुत मुश्किल से, because until 2018 it was that if she doesn't settle on medical nutritional therapy, straight away go on to insulin. They're not even allowed with the metformin in the guidelines, but now metformin and glyburide we've managed to push because FIGO has also recommended those two. When we say whether these newer drugs can be added, they want the data in pregnancy, which we are not able to provide to them. So if you go by the evidence and the approvals for the recommendations, it's not very easy for us to get it in the near future. That's where it stands as on today.
So rightly said, madam. Now there is a question from Dr. Vijay Lakshmi, and it is, she's asking, is it advisable to continue metformin in pregnancy for a known case of PCOD? And if so, how long to prevent diabetes in pregnancy?
Okay. There was one school of thought within our country, which we said that anyway, usually the metformin is continued up to 12 weeks as a continuum for the PCOS. So why don't we continue the same thing to the rest of the pregnancy? Because PCOS and GDM is a nexus. They are hand in glove. So if they are PCOS and little obese, they have high chances of becoming GDM full blown by 22 weeks. The other concern is Asians have 11 times more chance. So essay na taise, she is at a very high risk, so you are justified in giving. But actually, when we did the studies and we looked it up, it is not the metformin that you continue or not continue unfolds there. Even if you continue metformin, the diabetes can be prevalent. So as a preventionary precaution, it is not yet in the recommendation. If you're using for PCO, at the standard time of stopping, that is 12 weeks, you're stopping it as a standalone for PCO. In order to give it prophylactically for gestational diabetes, neither the literature support, nor the research support, nor the recommendation support is there. But many, in their mind, they're complacent, they feel safer. No harm, just give the metformin because ye patient to sunegi nahi, she will not maintain her diet and all properly. So then maybe I am at less risk for getting high blood sugar in her. So let her continue like that. Many practitioners are doing. It may not be totally wrong. It may be, out of constraints, that may be a better way of handling, but still we don't know yet whether that is the way forward. On the contrary, there are newer things like the food supplements, myodecairoinositol, vitamin D3, for example, which is hugely promising. Our women are vitamin D deficient, right? They anyway need vitamin D for vitamin D. So instead of giving plain calcium, if you give calcium and vitamin D, your prevalence of GDM will slash to half. That is what the studies world over are showing. In a depleted population of vitamin D, if you give vitamin D supplements, the incidence of gestational diabetes is far lesser because that is also an insulin sensitizer. So that is probably the safer thing to do as a blanket. Give folic acid, give iron, give calcium, give vitamin D. Maybe you will need to deal with lesser number of hyperglycemia.
Yes. And also there is a question from Dr. Kumbar, how to adjust the insulin dose in relation with the blood sugar fasting and the postprandial levels.
No, that depends on what kind of insulin you're using. So in our capacity building or teaching courses, it's a one-time lesson on what insulin to use, how to manipulate the dosage is very difficult, because we said that each patient has to be individualized. Sometimes the fasting may be high. Then if you give her a dose, the evening dose, which may make her hypoglycemic in the night, that is a more worse of a nightmare than what you would have actually landed up with. So we submit humbly that we are OBGYNs. Yes, we have taken a handle on managing the hyperglycemia to an extent, because we are testing everybody. We can give the diet and exercise advice. We can also dare to give the hypoglycemics. But when it comes to insulin, you need to link with a physician or a diabetologist on the telephone, take the advice, and if anything goes plus or minus, you can always fall back. Instead of surprising him, he is also in the loop with the patient. Yes. Not diabetologists and physicians are there as much as we want for the millions of women. So mostly we are managing by ourselves. The small group, it is still worthwhile in the interest of the patient. We cannot, because even the newer insulins, the combinations, the mixed variety of insulins, how they manage and give, that is clearly their forte. So I would urge on this platform yet again that please check with the concerned diabetologist if she's a fresh case of GDM. If she's already with a diabetologist and now she has become pregnant, then she's already linked with the primary care physician for her sugar levels. Yeah.
Yes, very, very, very nicely answered. And we should know, and we should work with a multidisciplinary approach. We should take help from the colleagues, because we all have to work in best interest of our patient.
Patients, yeah.
There is one more query. If a patient comes late in pregnancy, should we still do glucose challenge tests? Or at this stage, we can just go with a simple postprandial test? Dr. Seema has asked this question.
This is a very, very practical, very important question. Anytime she comes, please do the challenge test, because just the random sugar testing, just a fasting or just a postprandial, there's a good 63% chance that you will miss the state of hyperglycemia, because the body needs to be challenged. Whether the pregnant woman can respond to the challenge, whether she can briskly mount that much of insulin within her own body and fight with her own placental hormones and get her sugars under control. That is the philosophy of the challenge test. So do it any which ways for two reasons. One is that your mind is on the alert on the probable complications that you may have at the short term. Your decision of monitoring the baby, your decision of monitoring the sugar of the mother, decisions of multiple scans and the CTGs, etc., to decide the time and mode of delivery, everything comes into the picture in the short term, even for the immediate post-op care. But what is also more important is, long term, please do not lose handle on this patient. Finally, at the third trimester, you have discovered that she is a potential candidate for later on type 2. She may be just 25 today, and you have tested her late in pregnancy, but you have found she is hyperglycemic. You have done her best, given her the good outcome. But this 25-year-old, by the time she is 28, would have become a type 2 diabetic. She would not have known that she had in the third trimester. You would not have known because you have not tested. And she becomes at 28, 30, 32. She will end up with taking insulin for her type 2 diabetes. So even for that reason, it is so crucial to not to miss any patient in pregnancy with hyperglycemia, because with half the number of our women floating in our population undiagnosed, we were suggesting to the task force of the COVID that with the COVID test, whether you want it or not, please do the sugar check, because many undiagnosed diabetics are there who may suddenly turn serious. They don't know, so they have not given you the history. This is a good opportunity to tap the n number of millions of diabetics in the country as well.
So, Hema Madam, after such a nice talk of yours and explaining the queries, there are so many questions still coming on the diabetes. I think it is a favorite topic of everybody, and we cannot let you go very easily, because I know you have so much commitment, but there are still questions flowing, and Many are coming regarding the oral hypoglycemics and the insulin, and there is a question on role of ultra short acting and long acting insulin in pregnancy. So Dr. Abhilash is asking.
Well, can you do one thing? Can you collage these questions and send it to me on mail, and then we can always
Yes.
put it up in the.
Yes.
The four societies
Yes,
have joined
yes.
together. That's a wonderful opportunity. Each of the
Yes.
presidents put it on their website or put it in their groups, and it will be a
Yeah,
because
there are so many. We have so many questions here already.
any opportunity to reach and disseminate some information, we'll be quite happy to do that, because in the constraints of time, it's not only by commitment to another program, but you have a whole panel to go, and this is like an evergreen topic because there are a number of doubts which are arising, because it's not primarily our specialty, but we have to deal with it, because the
Yes.
and the only point of contact is an OBGYN most of the time. These women will not have any other access. So it is good for us to know a little more than the framework of OBGYN, because in medical disorders, to an extent that hypertensive disorders can be controlled by us, to an extent that hyperglycemia can be controlled by us, we have to pitch in our efforts and understanding to do that. Yeah?
Yes, surely, madam. We will see to it that all the questions are answered and we will send. So, please, Emma, madam, if really you want to give some last take-home message from your end for everybody, and then we can conclude your talk.
Yeah, the take-home message are only two. One is the Pehla Kadam. That means even today, in our Manyata initiative, when we have taken 1,000 hospitals on board, there were more than 850 hospitals who were not routinely doing the single-step test for hyperglycemia in pregnancy. It was done in a very bizarre, kabhi karo to karo, nahi karo to nahi karo. That means that is the scale. So as we take many more centers into the fold, this is the situation in private hospitals. So just imagine what may be in the public. So each and everyone in your leadership position, as your institutional head, please guide the juniors and the entire staff to dialogue with the patient that this test is important, how to do that test, and they have to alert you if the reading is more than 140. So the Pehla Kadam is the first thing. Second important message is that take home baby, take home mother, take home message doesn't end there. It begins because for the rest of her lifetime, she has to be on the alert for the potential possibility of becoming a type 2 diabetes. So don't ignore the long-term care, because if you are casual and you do not sensitize your patient, you are losing a wonderful opportunity to do your best to her. That is why all the adolescent girls, when we tell them about PCO, etc., slowly we are building the digital platform where they can go and access more information so that their health is in their hands. That's what we want to make them believe and move towards preventive care as much as possible into the generation next.
Thank you very much, madam. It was our honor that you were there for the webinar and you have given so much time and answered all the queries in detail. Thank you very much.
Thanks, and wish you all the best and great learnings from Komal and the brilliant galaxy of the panelists here. Thank you very much. Namaskar.
Thank you very much. Thanks. So moving on, now after the power pack discussion and talk by Dr. Hema Dibakar madam, we move on to our panel discussion on isoalloimmunization. And we go back to the history in 1939 when Dr. Phillips and Rufus published their findings about a 25-year-old mother who had a stillborn baby that died of hemolytic disease of newborn. Both the parents were of blood group O. So the husband's blood was used to give his wife a blood transfusion because she had PPH. However, she suffered a severe transfusion reaction. And since both the parents were blood group O, which was believed to be compatible that time for transfusion, they concluded that there must be some previously undiscovered blood group antigen that was present on the husband's red blood cell but not on his wife. And this suggested for the first time that mother could make blood group antibodies because of immune sensitization to her fetus RBCs. as her only previous exposure would be the earlier pregnancy. So that gave the concept of alloimmunization. And in 1968, a clinical trial began for administration of anti-D. And from there till today, we gynacs have been having patients with Rh negative, and we write in bold on their paper, and we take special care of these patients. We doctors and gynecologists still tell all our patients कि शादी के पहले कुंडली नहीं ब्लड ग्रुप मिला, but still we get these cases in day-to-day practice. And so we have to discuss some case scenarios, and we have with us the expert panel. The panel are from all the 4 societies which are the part of the webinar today, from Rewari, from Yamunanagar, Hisar and Gurgaon society. So we begin with all our questions and welcome all the panelists. So I begin with the first question to Dr. Seema Mittal. This is a case scenario. We have a patient who has come to us. She is a Gravida 2 Para 1 Living 1, 12-week pregnant patient, A negative, the blood group, and a routine ANC registration. She has just come to you and she comes. So what will be your clinical approach to this patient? Dr. Seema Mittal, you can unmute your mic now.
Thank you, Dr. Komal. Good evening, friends. It is really, it's a very nice evening when we had Dr. Hema. I wish to thank her for all the wonderful talk, and especially my panelist friends, Dr. Sarita, Dr. Rizvi, and Dr. Preeti, who supported and also spared the time, and the wonderful questions that we have received from you, Dr. Komal. Actually, we were planning a meeting in April in Rewari, and somehow the God has decided this way. And just a request also I want to make through this platform is for our candidate Dr. Mitra Saxena for practical obstetric committee to vote and support her. So this is a very nice question. I think it answers, answer to this question will solve many queries. Patient is Gravida 2. So history becomes very, very important. We have to know the blood group of husband, and we take it that husband is positive. Then we have to know the baby's blood group. Then as we proceed, the baby blood group, now we say that it is positive. So we have to ask the history, whether she received any anti-D in the previous pregnancy, before delivery or after delivery. Because before delivery, if we give anti-D, it reduces the chances of sensitization for the baby in future also. Then any history of blood transfusion, whether the baby received blood transfusion or mother ever received any blood transfusion in past, and whether the delivery was normal or cesarean was done, or there were any problems post delivery, that baby had jaundice or there was any exchange transfusion, and during antenatal period also was she advised any interventional procedure. So these are the histories I would like to take, and if it is uneventful past history, then we are comfortable. But if baby had any problem during birth or after birth, then obviously we will be alarmed. And ICT, I would like to do as soon as she's come to me. I would like to do her ICT. So that is my answer.
So very well said that you would like to go ahead taking the detailed history and doing the ICT, which is very, very important. Now, Dr. Sarita Gulati, what about the fetal affection, hemolytic disease of fetus and newborn? What is your take on that?
You have to unmute.
Hello, you can unmute your mic.
Sorry. Good evening, everyone. As the question itself tells, hemolytic disease for the fetus, it tells that there is hemolysis of red blood cells of the fetus. This hemolytic disease is seen in Rh negative mother carrying a Rh positive fetus, and usually it is seen in the second delivery. The first pregnancy, it goes unseen because very few fetal red blood cells pass through placental membrane during first pregnancy. It is only in 5% of patients that fetal blood cells pass in the first trimester, and 47% few red blood cells pass in 47% of patients, and it's at the time of delivery, or if there is any blood transfusion, or any instrumental delivery or abruptio placentae, when this red blood cells of fetus pass through the placental barrier, and they go, and in response to these fetal RBCs, immunoglobulins, antibodies, immunoglobulin M are formed in the maternal blood, and there is isoimmunization in the mother, which takes some time to occur, and this starts from 10 days to 1 month. But by the time of second pregnancy, these are converted into IgG antibodies, and they are transferred from fetal placenta to the from mother's fetoplacental barrier. They are transferred to the fetus, which in return go and attach to the blood RBCs of the fetus and hemolyze them. Due to this hemolysis, extramedullary hemopiesis activates, and there is enlargement of liver of the baby, spleen. There is decreased hemoglobin. The fetus becomes edematous, and there is decreased albumin. And depending upon this decrease in hematocrit, the baby can even die in utero. There is excessive formation of bilirubin, and depending upon the level of bilirubin, there are different conditions which affect the baby. If it is much more, then this can cross the blood-brain barrier of the baby, and baby can have conductus. So we investigate the patient which is Rh negative and husband is Rh positive, where we feel for hello,
Oh, yeah, yeah,
where
we can go on.
we expect in which case we expect the baby to be Rh positive. So we examine the patient, and we test her for antibodies. In primary, we do at 12 weeks, 24 weeks, then 28 weeks and 36 weeks. In multipara, we do it more frequently, and depending upon her status, we give her anti-D injection. If she is not immunized, there are no antibodies earlier, then we give her injection anti-D 300 microgram at 28 weeks of gestation.
Yes.
And
That's
accordingly,
very, yes.
pardon?
Hello. Yeah,
Yeah.
yeah. Your voice is cracking. Yeah.
So this depends upon maternal isoimmunization. We investigate her and decide when and how to deliver the patient. If she is asymptomatic, like there are no antibodies till 36 weeks, we take that patient to 38 to 40 weeks and deliver her at term. And after the delivery of the baby, we will see whether the baby is Rh positive. If it is Rh positive, then we will give her anti-D 300 microgram. We'll do DCT. If DCT is negative, in that case also, we'll give her anti-D.
Yeah, so we'll come back to the anti-D and all. We have many other cases to discuss, but just to rush through, because this is a normal case where we are discussing about the possible effects of Rh negative in pregnancy and what are the risk factors for fetal-maternal hemorrhage. So my next question to Dr. Suboi Rizvi, what are the three procedures with increased risk of fetal-maternal hemorrhage trimester wise? Like, what are the alarming, what we as obstetricians should keep in mind when we are managing patients in all the trimester? Please unmute your mic.
It's unmuted. Good evening. Can you hear me?
Yes, yes.
Yeah. So good evening, everybody, and thank you so much, Dr. Seema and Dr. Komal, for giving me this opportunity to read about Rh negative pregnancy after a long time. Because no matter how much we know, we always need to learn a lot. And I think 2 days was enough of time for me to revise. And good evening, Preeti. You are from my college only. So good to see you here. Okay, about the trimester, when we are talking about the fetal maternal hemorrhage, and okay, I studied from many these things, we realize procedure-wise in the first trimester, it can be a surgical termination of pregnancy or CVSA, chorionic villus sampling or fetal reduction in the first trimester. In the second, it can be like after 16 weeks, can be amniocentesis, chordocentesis can be, and again a second trimester abortion can be there. Along with that, if the treatment for ectopic pregnancy you are taking surgically, it requires, there is a fetal maternal hemorrhage. And then in the third trimester again, we have these conditions which like, I don't know how many people are doing external version, but then it is one of the causes of a fetal maternal hemorrhage. And then we have all the procedures that can have the laser procedures or the intrauterine transfusions, which are again a cause of fetal maternal hemorrhage. They can be stent placement. There can be therapeutic interventions which can lead to fetal maternal hemorrhage. And then, of course, in the last trimester, we have this cesarean section is again a cause of an operative intervention. And then twin pregnancy again gives rise to increased chances of fetal maternal. In that last trimester, there can be transfusions that can go bad, and that can again be a cause of hemorrhage.
Yes,
Thank you so
yes,
much.
very well summed up. And now, with knowing the background, we now go to a case about a fetal-maternal hemorrhage, and we will start discussing. So, Dr. Preeti Jain, we have a primary gravida. She is 6 weeks pregnant, B negative with spontaneous abortion, and she's come to you. So, is there any need to give anti-D in this patient?
Good evening, everyone. First, I would like to thank Dr. Seema ma'am and Dr. Komal ma'am for giving me this opportunity. I'm really honored to meet you on this platform. Meeting Dr. Hema ma'am, listening to her, it was such an informative session. So coming to my question, she's a primey, she's 6 weeks, and she had a spontaneous abortion. First of all, we need to have a husband's blood type. We assume it's positive, so she is a case of Rh negative pregnancy. Now, fetal blood antigens in fetal red cells, the Rh antigens, they can be seen as early as 6 weeks. So there can be chances the pregnancy outcome, whether it is a spontaneous abortion or a medical termination, or whether it's delivery, whatever be the outcome, even at such an early age, if she has an abortion, there are chances of fetal-maternal hemorrhage. So I would like to give an anti-D at this time. Though the dose of anti-D would not be a full dose, that is 300, but yes, a 150 microgram of anti-D I would like to give.
So very well said. We can't ignore, because any patient can have a later on problem. So anti-D half dose is usually recommended, even if she's a primary gravida. And now we come back to Dr. Seema Mittal. We have a gravida 2 para 1 living one 7 weeks. Now she's come with ruptured ectopic pregnancy. And definitely it's a ruptured, you're going to do a surgical intervention. So will you give anti-D? And if yes, what dose?
Unmute.
Yes, unmute your mic. Dr. Seema, unmute your mic.
Hello, thank you, Dr. Komal. I'm so happy. Everybody's so well read, and actually, after such a long time, we are reading. Lockdown has blocked everything. So this is a patient with ruptured ectopic. So obviously, there will be lots of intraperitoneal bleeding, and there are chances that there will be lots of fetal cells in the maternal blood. So one thing that we have to be very precautious is that we have to remove all the blood from the peritoneum. And since it's 7 weeks pregnancy, so definitely the fetal cells are there, and we have to remove whole thing completely. And in such cases, we should never do that auto transfusion, which we sometimes desperately do. And dose of anti-D, I would like to give 250 international units for her.
Definitely a great point touched on you, that the autologous transfusion what we can give should not be given in this patient. A very nice point you have made, and very well said about the patient, that yes, we give anti-D, and because the fetal maternal hemorrhage is more, we need to give the increased dose of anti-D for this patient too. Now coming to Dr. Sarita Gulati, we have another patient, a gravida 3 para 1 abortion, 1 living. And now she's 18 weeks pregnant, and she has come with an inevitable abortion. She is in labor, and when she comes, you can't do anything much, and she aborts. So post procedure at 18 weeks, what would be your choice of dose of anti-D and what is recommended?
Since she is gravida 3 para 1 A1, we'll have to take her earlier history, her babies are positive or negative, or whether she was given NTD earlier or not. And in this case, I will like to give 300 microgram to the patient.
Yes.
Since
So
yes,
yes, madam.
yeah, I like to give 300 microgram dose to this patient.
Okay. And now she is an incomplete she's aborted and she has a previous history of abortion. So I feel this is going on to something else. The anti-D is one part, but we need to know if she is having which pregnancy was an abortion. This is the third pregnancy. The first may be a living. So a history and the cause for abortion also we need to investigate apart from the anti-D what we will offer. And I take it very well your point that we will require to give her the full dose of anti-D for this patient. Okay. So, Dr. Suboi Rizvi, now routine antenatal dose, do we recommend in pregnancy a single dose or a double dose? And if you are giving in pregnancy, do we still give the post-delivery immunoglobulin?
Yes.
So what is your take on that?
Okay, thank you once again for this question. So what we have, they first of all when they started that okay, we'll give it post delivery a 300 microgram. But later on by 1970, I think Brown observed that if we give antenatal anti-D, then the results are much better in the future pregnancies of the same lady. So they started giving a single dose of 28 to 30 weeks. And now there is a thought of giving double doses, one at like 28 weeks and the other at 34 weeks. But the consensus is that it is better to give a single dose at between 28 to 30 weeks. The other thing which I would like to say here is that since before giving anti-D, you have to take the consent also, which normally we don't take a consent from the patient before giving anti-D. Secondly, they said, okay, if they give anti-D at 28 weeks, by 40 weeks, many times the titer decreases. So there is a school of thought that they said a repeat dose can be given at 40 weeks. Still, they are not clear about that, but one dose at 28 to 30 weeks is very important. If it is missed, then anyway give a dose whenever the patient comes to you, even after 30 weeks. Okay. Now, once the patient delivers, then you can test the baby's blood group, and if it is positive, give for the full dose of 300 micrograms to the mother, irrespective of the fact that whether she has received in the antenatal period or not. Secondly, if there has been a procedure in between and you have given the routine antenatal prophylaxis, but if the procedure is there which has resulted in a feto-maternal transfer, then you have to repeat the dose of 300 micrograms of anti-D in the same pregnancy also. And this is what I would like to say at this particular time.
Yes, very, very well said that irrespective of the antenatal, if there is the evidence of fetal-maternal hemorrhage, we still need to give the dose. A very well made point and very well explained the importance of all the dosage in antenatal and post-delivery. So now we go to the another case scenario, Dr. Preeti Jain. She's a gravida 2 para 1 living one with abruption at 34 weeks of pregnancy. And we know that all patients now what we are talking are all Rh negative, and we require to take her for an emergency LSCS. So here the suspected feto-maternal hemorrhage is more. So how do we assess the feto-maternal hemorrhage and what test should we do in such patients? Dr. Preeti Jain.
Ma'am, very good, a nice question, because when I was reading RH, this was the first thing when I came across this topic, when I came across this portion of the chapter, then I thought we really don't think about this in practice, that actually whether the feto-maternal hemorrhage is large or it is small amount, that 300 microgram of routine dose will take care of it. There are some cases where like abrupt show or maybe twin
Blood
delivery,
thingy.
or when the
Blood
feto-maternal hemorrhage is much larger as compared in a normal case. routinely 300 microgram of immunoglobulin of anti-D would neutralize 15 ml of fetal red blood cells. So if we suspect a larger hemorrhage or more than 15 ml, then we need to see whether do we have any tests to see that how much hemorrhage has actually been done, so we can quantify the amount of blood went into the circulation. So I came across, we have two things we read in undergrad's book, the KB, the Kleehor Bedke test, the KB test, where we can see the percentage of fetal blood which went into the circulation. It is a very tedious test. There is a formula incorporating maternal blood volume, maternal weight, the fetal percentage of fetal blood cells which went into the circulation, and neonatal hematocrit. And now these days flow cytometry has come across, which is a very easier procedure which give us this test. When I came across this portion, then I called my lab people that, do you actually do this? So that, ma'am, we don't do it because nobody has asked any time. Because I also, they just give a 300 microgram and then we think it's sufficient. But no, we should quantify the feto-maternal hemorrhage. And if the hemorrhage is more than 15 ml, we should repeat a dose, because 300 microgram will only neutralize the 15 ml of fetal blood cells, fetal RBCs. If the hemorrhage is more, we need to repeat the dose. It was said that 5 doses can be given in a day of immunoglobulin. That's my take on this, ma'am.
So we can step up and increase the dose of immunoglobulin according to the feto-maternal hemorrhage what we get. And that is very important, because we patients with massive hemorrhage and really we don't know. So we should analyze and then act accordingly. A very good message given. And in case, it all depends upon the patient. Will that change if the patient is a multigravida, like a gravida 4 and not interested in childbearing? Still we need to give that much anti-D, or we can withhold anti-D for such patient. What is your take on that, Dr. Preeti?
Ma'am, I think there is no harm in giving it, because she might need a blood transfusion in future or something like that. If she needs a blood transfusion, then giving a dose of anti-D gives us no harm. She can be given. I think she should be given an anti-D, because it's not only
patients.
We should offer the patient, and if she says, okay, I want to take it, then should be given. And I want to ask, ma'am, whether you people quantify, do you? Because in Hisar, I don't know about other cities, but do we quantify the feto-maternal hemorrhage?
Ideally, you need to quantify, and if you know that there is a massive feto-maternal hemorrhage, we definitely need to quantify. But the traditional tests, the KB test and others are not much done. Even when we go to know the antibodies, we are supposed to track it according to that Lilly's curve and find out whether they come into mild, moderate, or severe isoimmunization. We are not doing the textbook things which we have learned, but definitely the test, the feto-maternal hemorrhage, the ICT, which are the standard, which needs to be done. Even there are many studies which shows that we need to quantify if the patient is interested into further, like patient is primary gravida or a second gravida. So in those patients, we need to emphasize and give them adequate dose of anti-D. But in case there are some patients also who are not willing to take the increased dose of anti-D because maybe there is a cost factor, or maybe they say that it is not required, because when we counsel them for anti-D, as Dr. Suboi said, we do take a consent of patient.
Negative consent is equally important.
Yeah, so instead of taking a positive consent, what we take is a negative consent. There are some patients who want to do a tubal ligation. So they say that we will not take an anti-D, we are doing a tubal ligation. So we don't take a consent to give an anti-D, but if they refuse anti-D, we take a consent in such patients. So that is the practical thing what we follow, and this is very important. So now coming to the antenatal surveillance and everything, the question is open. What about how often do you do in USG or a Doppler in this patient, in isoimmunized patient, and any other specialized diagnostic test? Anybody can take the question. We can go with Dr. Seema to begin with.
Dr. Komal, I just want to know that what is the single test you would advocate for fetal-maternal hemorrhage if at all we have to do? I'm still not clear.
Flow cytometry, I guess.
Yes, Dr. Suboi.
Flow cytometry is a good test. They have seen like it's better than the KB test now. So I think we should ask our lab to go ahead with it, because here the fetal hemoglobin is not, actually many times the fetal hemoglobin is otherwise also raised, which is picked up by KB test, but not picked up by flow cytometry, because they are like specially rated. So I think flow cytometry can be actually come into our practice, and this is the reason why we hold such webinars, that we tend to learn and improvise our practice. So, so that is one thing which I have thought, and I really think we should go ahead and many
Yes,
times
I think we can tell our lab people to come forward with this test, because it is actually very important to know the amount. Without knowing it, we are not doing justice to the patient.
There are simpler tests like Rosette test and all. They are also one of those tests, but actually we are not doing any of those tests.
Exactly.
Yeah, so we Indians are lagging behind in few things, although we are quite ahead in many things. So we need to learn and study.
Okay.
So about the how to take the patient, you are saying, ma'am? Which question?
Yes. How to, because we have now a lot of questions from the audience also, but in the meantime we'll just talk for the purpose, because many questions are overlapping about in general how will you do the imaging, ultrasound, Doppler, and when would you do it. So that is my question.
Dr. Komal, 18 weeks is the ideal time when it should be done, because before that there are minimal chances of fetal-maternal hemorrhage, and as the hemolysis happens, there is fetal anemia, so there is increase in systolic volume of the blood, so there is peak systolic volume will increase, and if it is more than 1.5 mm, then we have to go for exchange transfusion and look for other fetal parameters. So this is very, very essential that after 18 weeks we are going for Doppler flow studies, and if we find a compromised fetus, we have to work accordingly.
And what is your take on intrauterine transfusion? As Madam mentioned about exchange transfusion, Dr. Suboi, you can add into it.
Okay, ma'am. First, I would like to come with the previous question. Like whenever you have a patient, you get the ICT done. And if ICT is 1, like in the ratio 1:16, lesser than that, then you can have a repeat every 2 weeks, the ICT test, and then you can, if it is normally not increasing, you can deliver as per the normal baby.
And if it is positive?
If it is more than 1:16, like positive in both the cases, 1:16, lesser than that, and more than that, if it is more than 1:16, then you have to repeat the ICT every 2 weeks. And you have to start the Doppler by 20 weeks of pregnancy. Okay. And now if the MCV, like if the mean systolic, the MCA peak systolic volume is more than 1.5 mom, you repeat the Doppler after 1 week again. So if again it is raised, or it was like previously raised than the previous one, then you assess the cord blood. Like you see the other features of anemia, and then you perform chordocentesis. If the hemoglobin is less than 10 gram per deciliter, then this patient is fit for exchange transfusion. So whenever you are seeing a patient who is seeing a fetus that is showing the signs of anemia, once you are going to do chordocentesis, you should be prepared for the transfusion also. It cannot be 2 times, like once you are assessing the hemoglobin and then you are taking the, so in one sitting only you can go ahead with the transfusion. So actually 3 people will be required. One will be doing the taking the cord blood and assessing the hemoglobin. The other will be having the package of that, and the third will be doing the pushing of the transfusion. Now what we required in cord blood transfusion is that we want an O negative, and basically it has to be either ABO compatible. It should be CMV negative and HIV HBS negative blood. And basically it has to be irradiated, and then you have to have it ideally within 24 hours. The procurement of that blood should be within 24 hours before transfusion. So that is the blood, and that is the best blood. Or anyway, like if it is not there, then within 5 days of the planning transfusion. So ideally, the thing is that when you transfuse 10 ml of blood, and at the same time you monitor the fetus also. And post transfusion, you again from the same needle take the hemoglobin assessment again once you have transfused, and then they take the fetal parameters again once the transfusion is over. So that is my take on it. Thank you so much.
Yeah, very, very well summed up. And we have many questions flowing. Many are which we have already covered and we covered in our question answers, but some we will discuss. They're really genuine. And Dr. Archana Agarwal is asking, do you routinely give anti-D in third trimester in a RH negative patient, even if the ICT test is negative? So this is a very common thing. We get, this is the most common what we encounter. So what is the take of the panel?
Ma'am, definitely, this is the point of monitoring. We should definitely give a dose on the third trimester. And see the dose we give in the third trimester, it is said the half-life of anti-D is 14 to 24 days. So if the delivery happens after 3 weeks, again, which Dr. Subuhi has already told that it is one school of thought that we can give one more dose of anti-D. That protocol should be followed even if the patient is ICT negative. Giving of anti-D should not depend upon the ICT, like if it is negative, should be given.
Actually, this is the confusion. ICT negative are the people who required anti-D actually.
Require anti-D, exactly.
And ICT negative are the people who require, that is the primary prevention. When the patient is ICT positive, then that is the titration, okay, 1:16, then they come into the point of secondary prevention. Then we have to monitor their MCV and MC, and we have to see how it is increasing, how is the ICT. Every 2 weeks we have to see if it is more than 1:16, and every 4 weeks if it is less than. So ICT negative are the people who need anti-D actually as a source of primary prevention. And in US and all, they have this pre-fetal DNA, like which we don't do, like UK and all. They get the genotype of the father done, whether it is homozygous, heterozygous, and then they plan for the NTD. But in India, it is not very it is not cost effective. So normally we are not doing it in routine, but we are doing it in patients who had previous history of IUDs and erythroblastosis. We are doing, for those cases, we can get the father genome also done. And the pre-fetal DNA also can be done in high-risk cases. But it is very expensive to do all these things in a routine kind of way. So we assume that can be there. If the ICT is negative, give anti-D. And if the ICT is positive, titrate, see the titer and accordingly manage. That's it. Thank you.
So in our scenario, we go in it's easier to offer a patient an anti-D rather than making them go through all those investigations and everything.
Yes.
But definitely, I think what you said about the genome of the father, which is done in cases of repeated, if they have RH pregnancy leading to hydrops or any fetal compromise, definitely we can offer these tests to our patients too. There are many questions actually which we have actually covered, that whether to give anti-D in a primary and how to detect fetal-maternal hemorrhage, and if there is a twins and a triplet, does antenatal and postnatal anti-D needs to be increased. So I think we have discussed all this, but there is one question that if the male partner is RH negative, should anti-D be given or not? Dr. Sadhna Sinha.
Definitely not. Definitely not.
So that is the first test which Dr. Seema Mittal said, that first test we do for negative patient is the husband's blood group. And the story ends.
Yes. But you take the history also, because at times there are antigens which are like K, D, small c, small capital C. So take the history. If there is a history of something that has happened to the previous baby, please do all the anti things which you want, because we should not be having surprises. Because as a routine, we only do anti-D here, but otherwise there are a lot of other antigens which come up as surprises, and especially the K1 is very, the E and the small c again are things that have to be looked into. So a careful history is very important before just saying, that is my take on it.
But I think routine practice, we do get surprises, a lot of surprises.
Yeah, that is actually that is important. That is why I think the webinar is important, because we read the RCOG guidelines and the ACOG guidelines and the FOXI guidelines, and then we come to see hum kar kya rahe hain. So then we realize that we are just doing the midway kind of practice chalta hai wala, and we are really not focused on many things, and that is why I take all the opportunities to study more, because the more you study, the more things you don't know. So that is one of the things which
that is the reason we have this webinar, so we know what is happening and what are the common practices in every corner of India, and we are updated. So There is one more question. An Rh negative pregnancy, Gravida 5, Para 4, living 2 with 2 full-term IUD. Now she's 33 weeks gestation. USG parameter of 36 weeks now. So when to induce this patient for labor? So what is your time of termination of every Rh negative? In short, will you induce or will you wait for term?
This particular patient should be induced after steroid cover because by ultrasound she's already 36 weeks and maximum isoimmunization what happens in last 2 weeks. For such patients, 2 weeks before EDD we normally also induce all such patients. And this particular patient has 2 IUDs. Maybe we can ask her the history. What time was the IUD, like when it happened?
Full term IUD, what is written?
Full term. So she should be 36 weeks. She should now be induced after steroid cover.
I think she is the right time for induction and she requires induction at this time.
And a good color Doppler before induction is very important because
at times
are to be excluded.
clinician judgment becomes the best thing out of all you realize ultimately. So I think she should be induced.
Yeah.
So
very nice discussion.
Dr. Komal, we want you to touch on this also. Decision for IUI should be taken. This is very important question.
I didn't get you, madam.
decision of IUI.
You said
Intrauterine transfusion.
Yeah,
IUI or intrauterine insemination or
IUT.
IUT.
Insemination also can be
IUI. I was like, where? So intrauterine, I think it is very well covered. Dr. Suboi spoke that if we have the ICT is positive, then the decision of intrauterine. But at full term, definitely we don't wait. In this patient, she requires delivery. So there is no role of intrauterine.
My patient had 8 miscarriages and she wanted IUI from any donor. She is recommended. IUI and intrauterine insemination.
Okay. IUI.
Okay. So
husband badalna chahte.
So I want to share a good news with you that we don't have viewers only from the local societies. We have all over India, and we have few viewers join us from even Saudi Arabia. So Haryana societies have gone global, and this is a real good news.
Ma'am, real congratulations to Seema Mittal ma'am and you've come forward with such good discussions and topics now. So everybody is so interested and keen on listening you.
So we have more waiting now, Dr. Komal.
Yes, so really great discussion, and I think for entity also we had a real experts who was so well knowing what is the scenario, and we discussed it. And whatever questions have come, we have almost covered everything, and it was a great discussion, great meeting you everybody, and all the Haryana societies are shining high in the map of India, and we look forward to do more and more programs, and we need to bridge Bharat. And I really thank you, all of you from Foxy Medical Disorders in Pregnancy, Team Science Integra, that is TOG, and our sponsors, Bharat Serum, for bridging the Bharat and making us all very close and together. Until we meet next again, goodbye from me, and stay safe, stay healthy, and take care. And we'll see you soon, and we are planning to keep more programs. This is just the beginning of our series of webinar which we'll be planning. So
Thank you, ma'am. Thank you so much, ma'am.
Thank you so much. Thank you, Dr. Seema, Dr. Komal. Congratulations again.